we present an innovative technique of trypan blue capsular access marking for well-centered capsular access in cataract surgery without the use of sophisticated projection system. We have no financial interest in this presentation. Refractive outcome of cataract surgery depends on proper size and centration of capsular axis. Decentration of even 0.4 mm will cause a change of 0.25 diopter in the post-operative outcome. Capsular axis IOL optic gap will induce astigmatism of 0.5 diopter or more in the long run. Trypan blue air bubble assisted capsular axis provides perfect on the capsule marking for performing well-centered capsular axis of desired size and shape. Here we see the routine on cornea marking for the capsular axis. Here with the change of gaze due to parallax, the marking on the capsule and the marking on the cornea do not match. We have devised this air bubble assisted trypan blue marking wherein parallax is taken care of, and irrespective of the gaze of the patient, the marking on the capsule will remain same. Here we see corneal marking done with the help of routine corneal CCC marker. Through the side port, we will now inject trypan blue dye inside the anterior chamber. We slightly remove the aqueous so that we get the adequate size air bubble inside first. This air bubble has to match the corneal marking done with the corneal CCC marker. We wait for the dye to act and then inject visco and get out the air bubble in a single go.
The video is not.
Now we can see there is a clear demarcation on the capsule of the size of the corneal marking done with the corneal marker. Now the surgeon does not have to focus onto the cornea. He just goes by the demarcation onto the capsule itself, and hence you can get a perfect circular capsular axis of the desired size and of the desired centration with this technique of demarcation onto the capsule itself. Here again we see a marking on the cornea. This is just for the reference. Now we inject the air bubble first and then the trypan blue. Now we titrate the size of the air bubble to the corneal marking. So that gives us a reference of the size of the intended capsular axis and also the centration. We ask the patient to look into the light and we center the air bubble onto the central Purkinje image. Visco is injected and we get out the air bubble. Here you can see the demarcation onto the capsule itself. So this makes our job of doing a capsular access much easier, as we are directly having a demarcation onto the anterior capsule, and even if the patient moves the eye, there is no effect of parallax as against a marking onto the cornea. Secondly, the surgeon can focus directly onto the capsule rather than focusing onto the cornea and back to the capsule. So we are just following the demarcation line as made by the trypan blue and air bubble assisted technique, and we get a desired size capsular axis right in the center of the capsule. We proceed with the technique of phacoemulsification that is convenient for us. We use a phaco slice technique here, and once all the nuclear matter is out and we get a good cleanup, we inject the desired IOL inside the bag. Once we dial the IOL haptics inside the bag, we can see a well-centered IOL and the margins of the capsular axis overlapping the optic equally on all the sides by about 1 mm. Here we just put the dye on to show you the marking onto the cornea and the marking on the capsule. So well-centered IOL with equal overlap on all sides, what we intend is achieved by this technique. Thank you.
Very innovative. The only thing is, what I don't understand is, because when you put an air bubble and I put trypan blue underneath, the trypan blue stains the capsule uniformly. For you, the center is not stained much, the ring alone is stained. How is it possible?
Sir, there's an interface between the air bubble and the aqueous. So at that interface, you get a different demarcation line. It's actually, the capsule is stained because as you saw, after putting the air bubble, we sort of paint the capsule with the trypan blue. So we sort of, just inject trypan blue underneath the air bubble. So the capsule is stained, but at the interface, there is a different kind of a ring which forms. So that's the interface. The capsule is stained throughout, but there's a different interface. If you
the interface is stained more.
Yeah, interface is stained more. So if you can just correspond that to your corneal marking, that gives you a marking on the capsule itself.
So basically, it depends on the duration of air bubble, like how long the air bubble stays. The marking will be that much stronger.
Yeah, so once you put the air bubble and then you put your trypan blue, just wait for a few seconds and the staining the way we do routinely. But due to the interface, there's a different marking at the interface level. That's the difference. So
no, I want to understand,
yes.
like what do you do different than like everybody do?
Yes.
Like everybody put
Yes.
a bubble,
Yeah.
everybody put a
So
stain.
what
extra is to be
Yes.
done in this case?
Yes, what we are doing is we are first marking onto the cornea, and then
Okay.
the same marking we are matching onto the capsule. So normally we do a corneal marking and then inject air of water size and then put the dye. But here we are trying to match the size of the air bubble to the corneal marking, so you get definitely a distinct ring at the interface, which corresponds to your corneal marking. So because it's very difficult because of the parallax to shift your gaze from the corneal marking to the capsule marking, and many times the corneal marking with the corneal wash goes away. So and parallax is also there. If you see, the corneal marking at the end was looking different from the actual corneal marking on the capsule because the parallax, the patient keeps, most of our topical, so patient keeps on moving. So parallax is also taken care of.